I'm Dr. Mark Socinski. I'm the Executive Medical Director of the Advent Health Cancer Institute in Orlando, Florida. I'm also an active member of the Institute's Thoracic Oncology program. One of the biggest challenges in the practice of thoracic oncology is the population of patients with extensive stage small cell lung cancer. We've had a standard of platinum etoposide in extensive stage disease. I don't think it matters whether it's cisplatin or carboplatin. That has been the mainstay of treatment for well over 2 decades, if not 3 decades. There have been no fewer than 40 randomized phase 3 trials looking at new strategies, targeted therapies, anti-VEGF therapies, 3 drugs versus 2, 4 drugs versus 2, so on and so forth. And none of these trials, none of these 40 trials have moved the needle in this setting until Empower 133. Empower 133 simply grafted atezolizumab onto a doublet of platinum etoposide and showed a significant PFS as well as overall survival benefit. It was real, it was meaningful, but it was modest. And this trial did include maintenance therapy, and I think maintenance therapy with atezolizumab by itself is an important part of that strategy. That was the first trial we had. Shortly following Empower 133 results were the Caspian results, which essentially almost the same design with the addition of durvalumab to platinum etoposide and almost identical results. I would challenge anyone to look at the Kaplan-Meier curves of both PFS and overall survival if they weren't labeled, and you pick which one is durvalumab and which one is atezolizumab. It would be difficult to tell. The hazard ratios were both around 0.7, 0.75 for overall survival, very similar PFS numbers, very similar response rate numbers. And again, there were no new safety signals with regard to adding immunotherapy to chemo or adding the chemotherapy to the immunotherapy. So I would call this a safe treatment. Last year at ASCO, we had 2 further trials with the PD-1 inhibitors. Remember, atezolizumab and durvalumab are PD-L1 inhibitors. Pembrolizumab and nivolumab are PD-1 inhibitors. And at last year's ASCO, we had a keynote trial, apologies for not remembering the number, that added pembrolizumab to platinum etoposide. And it was close. The hazard ratio was 0.8. It did not achieve statistical significance per the statistical plan of the trial. The p-value was about 0.016, but the statistical design, because of the multiple comparisons, required for it to be positive to be less than 0.013. So it didn't quite make it. There was a second trial done, actually a phase 2 trial, grafting nivolumab onto platinum etoposide, done by the Eastern Cooperative Oncology Group, which showed a significant benefit. Actually, it was the greatest benefit, but remember, it was the smallest trial and was a phase 2 trial. So we typically see better results in phase 2 than we see in phase 3. Now, even though the nivolumab was phase 2 and the pembrolizumab trial was technically a negative trial, I think it really solidified. These 4 trials are very consistent in their effect. They're all positive. Rarely in oncology do we have situations where we have 4 trials that are all pointing in the same direction. There were no new safety signals for any of this. So I do think that immunochemotherapy is the standard of care in small cell lung cancer extensive stage, although I will be the first to admit that the benefits are modest, they're real. And we've been so hungry for an advance in extensive stage small cell lung cancer that I think we have embraced this as the new standard of care. But I also think we have to admit that the benefit is modest, and we need to continue looking at new strategies to improve the overall outcome for patients with extensive stage small cell lung cancer.